Good evening, sir. Respected teachers and friends, we would like to welcome you again to a special series program to bring you the best surgeons to your home. A series that will highlight the progress of surgery still today and its future, told to you by the leaders in that field. For the fourth episodes, we present to you Dr. Isaac Howley, a reputed trauma surgeon attached to the Department of Trauma Surgical Critical Care in Elvis Presley Memorial Trauma Center in Memphis, Tennessee, who will provide the basic guidelines to manage a blunt abdominal trauma and with special reference to liver injuries. Dr. Isaac Howley is an MD who's a physician in the regional health, One Health, who is a board certified in preventive medicine, critical care, and surgery. And he is attached to the Department of the Trauma in the Elvis Presley Trauma Center. He has received his medical degree from Brown Dartmouth and completed both his internship and residency in surgery and preventive medicine in Johns Hopkins in Baltimore, Maryland. He went on to complete a fellowship in the University of Maryland Shock Trauma Center in surgical critical care and acute care surgery. Dr. Howley's patient care philosophy revolves around communication. Outcomes are subject to the vagaries of chance, but communicating honestly and empathetically with my patients and their families is one good thing that I can completely control, he says. Dr. Howley also has training in preventive medicine and public health that gives him a unique perspective in the effects of health systems on patient care. He has numerous board certifications and education and experience and numerous publications in various reputed journals. We would like to welcome Sir to our Assam chapter of ASI for this small webinar. We're very grateful for you to give us your valuable time, sir.
Thank you very much for this opportunity to speak. I'm deeply honored for the opportunity. I have traveled many times to India, but never to Assam. So at least now I can say I've been to Assam via Zoom. And I'll share my slides. All right, so I'll talk about abdominal trauma with a focus on the operative management of liver injuries. I can see this is a audience of consultants, and I'll skip some of the early slides, which were geared more towards trainees, give us a bit more time to talk about liver trauma. I try to include some key points with any talk I give. So in general, the keys for identifying patients who require immediate emergency laparotomy are physiology, especially hypotension, physical examination, especially peritonitis, and increasing abdominal distension, and the FAST exam to show peritoneal hemorrhage. With regards to liver trauma, most liver injuries can be successfully managed non-operatively, and even some very severe liver injuries can be very successfully managed non-operatively. Operating on a liver injury that isn't actively bleeding may release tamponade and cause it to bleed dramatically. So my advice is to don't poke the bear. If the liver isn't bleeding, leave it alone. And then I will discuss my entire, all of my tricks and algorithm for operative management of liver injury. The key maneuver for this is the Pringle maneuver to control the portal triad, which is both diagnostic and therapeutic for the source of liver hemorrhage. And I'll skip these early slides, which I think are somewhat less interesting for experienced surgeons. And I'm sure you all are quite facile at performing a laparotomy and exploring the abdomen. But I'll talk a bit about damage control, which is a major paradigm, perhaps the major paradigm for exsanguinating abdominal trauma. So the term damage control comes from the Navy. I don't know which country's Navy, but I believe it comes from about the time of World War II and refers in the military to any temporary repairs performed to prevent the vessel from sinking and to allow it to continue in combat. So things such as fighting fires, plugging leaks in the hull, or even flooding the other side to level the vessel out if it's listing to the side, shutting off or rerouting fuel lines, and getting the motors and the weapon systems working again, with the goal not to make the ship in perfect condition, which often requires a port and a dry dock, but to allow it to continue in service. This term from the military was applied to surgery first in 1993 with this landmark paper by Dr. Rotundo, and refers mostly to an abbreviated laparotomy with limited goals. So not the definitive repair of all injuries, but first and foremost, controlling hemorrhage, and secondarily, controlling the spillage of GI contents from bowel injuries, with a very clear goal of minimizing time in the operating room. What I was taught as a trainee, and I still try to follow, is to keep an operation, if the patient is bleeding to death, I try to keep the operation under 2 hours. And the reason for that primarily is that when the patient's abdomen is open in the operating theater, they rapidly lose body heat and fluid, and this hypothermia contributes to coagulopathy. So after controlling hemorrhage and controlling spillage of GI contents, to get the patient out of the operating theater faster, temporarily closing the abdomen is the key maneuver. And then the patient can be warmed, resuscitated, their acidosis can be corrected, their coagulopathy can be fixed post-operatively. Sometimes patients will resume bleeding rapidly as they're resuscitated, as a vasospasm releases somewhere in the abdomen, and they may need immediate re-exploration, but ideally bringing them back to the operating theater once they are fully resuscitated. So why leave an abdomen open? There's several papers going back to that paper by Dr. Rotundo showing much greater survival in patients with true exsanguinating hemorrhage with a shorter operation. But in clinical terms, in increasing order of frequency, the reasons to do this are, first, if there has been a mesenteric injury and you're concerned about the adequate perfusion of the remaining intestine, rather than taking it out all potentially threatened intestine, you can resect only the obvious ischemic bowel and return for a second look in 24 or 48 hours, much as for mesenteric ischemia from an embolus. More frequently, perhaps most frequently, patients often raw tissue oozing of the liver or the retroperitoneum can be controlled most readily with packing, and the packing can be left in place for 24 or 48 or 72 hours before return to the operating room. And then perhaps the best reason, maybe the most frequent reason to leave an abdomen open is severe physiologic derangement, specifically coagulopathic bleeding. If the patient's clotting factors have been depleted and they begin to ooze from any disturbed tissue, a return to the operating room once they've been fixed can evacuate all of this extra bleeding and make sure everything looks proper before closing the abdomen. Our trauma center, and for most, if not all, trauma centers in the US at least, really have realized in the past 10 years that we were applying this paradigm too liberally, and actually we've been trying very hard to claw back to only leaving the patient's abdomen open with a temporary closure when it's truly necessary. And so there's, while everyone believes we do this too often still, there's substantial variation between surgeons in which patient we leave open for a second look. Part of this paradigm, especially in penetrating trauma, but also in blunt trauma where there are bowel injuries, is not perform the anastomosis at the original operation. The benefit of this is allowing the patient a shorter operation and less loss of heat and perhaps less bleeding, but it does have downsides. There may be an increase in the anastomotic leak rate of the small bowel, and perhaps even more so in the large bowel, as seen in a large multi-institution observational study of enteric injury managements in temporary abdominal closure. My institution here in Memphis, Tennessee, has published extensively over the past 2 decades on management of destructive colon injuries. One of these papers in 2014 addressed the risk of leak from a colon injury if the patient has had an abbreviated laparotomy. We had identified long before then that receiving at least 6 units of packed red blood cells is associated with a higher leak rate in colonic injury. And our protocol, which I believe is widely followed by other trauma centers, is that if the patient has received at least 6 units of packed red blood cells in resuscitation, that we perform a ostomy to divert them. Unfortunately, even when the patient is left in discontinuity and brought back for an anastomosis once they're fully resuscitated, that risk of leak from anastomosis does not go down. So we still divert these patients in that case. And then finally, a second look operation, a re-exploration, does use extra resources. It takes more of the surgeon's time in returning a second time to the operating room and reopening the abdomen. And there are a few things that use resources more in the hospital than a trip to the operating room. Along with the damage control surgery paradigm, we talk often about damage control resuscitation, which term refers less to the operative techniques as to all of the medical management of bleeding and acidosis and coagulopathy. And I won't go into detail on this. This is a large topic and could easily be its own lecture about the benefits of balanced hemostatic transfusion. Whole blood appears to be best, although most American hospitals do not have the logistic capability to keep whole blood, which only can be stored for about 7 days. But the next best thing is balanced transfusion, incorporating plasma and platelets in equal measure to packed red blood cells. The role of cryoprecipitate or fibrinogen concentrate and tranexamic acid is somewhat more controversial, but may have an important role in hemostatic transfusion. And then the aggressive correction of acidosis and hypothermia. I don't know how frequently temporary abdominal closure is performed in India or Assam. So I will briefly cover the most common techniques for doing so. The most basic is to reapproximate the skin, leaving the fascia open using towel clips, penetrating towel clips. This is very quick and does not allow for bleeding or weeping of edema from abdominal viscera to be measured. Unfortunately, also the towel clips interfere with any X-ray or CT scan that might be obtained post-operatively. I have not personally done this, but I know it is still used with some frequency in some institutions. Another option is, I believe this was first reported in Colombia, and so it's known as the Bogota bag, is to sew any sterile plastic sheeting. In my institution, when we perform this, we typically use a sterile X-ray cassette cover, but you can also cut open a IV fluid bag and sew the sterile inside down over the abdominal viscera, sewing it to the skin edge. The advantage of this over the towel clips is that there are no metal bodies that will interfere with an angiogram or a CT scan, and you can visualize the bowel blood supply or the accumulation of blood underneath the plastic. Although again, you can't measure the fluid losses. I typically will use a vacuum dressing for temporary abdominal closure. Most frequently, I use and have used in training as well, a product made by, it's now a subsidiary of 3M, called the AbTheraVac. And I know prices differ wildly between different institutions in the US, and I'm sure even more so in India. But to me, the biggest downside of this is its expense, which in my institution costs about $800 in consumable supplies. There are at least theoretical concerns that providing suction to the abdominal cavity may exacerbate bleeding. But the advantage of this, and the system incorporates a plastic contact layer that lies over the bowel, and then a foam sponge lying on top of that, and then a occlusive adhesive drape that attaches the skin over top, and suction is applied to the sponge. So that does allow blood or edema to be sucked out of the abdomen and measured for more closer measurement of the patient's fluid output. I am dubious that this effect is real because it comes from research papers paid for by the manufacturer, but they claim that there is a reduction in inflammatory cytokines with the use of this suction device. The other suction device I use, largely depending on my mood, whether I use the AbTheraVac or this, is essentially a homemade version of the same thing, known as the Barker vac, or in my fellowship at the Shock Trauma Center, we typically call this a poor man's vac, using a 10-inch sterile plastic drape to cover the viscera, covered by operating room towels and nasogastric tubes or chest tubes to apply suction, then a layer of gauze, and then a adhesive plastic sheet. And then the chest tubes or nasogastric tubes can be attached to wall suction for the measurement of fluid output. The end game of this, whenever possible, is delayed fascial closure. Once GI continuity has been restored and bleeding has been controlled, this should be attempted as early as possible. There is observational evidence that the longer the interval from injury until attempted fascial closure, the lower the chances of successful fascial closure. And if the patient's abdominal wall is not closable due to edema, within 2 or 3 days, their abdomen should be taken and washed out, as the risk of deep abscess increases with a longer interval between lavage of the abdominal cavity. Even with clean operations that don't involve spillage of GI contents, there seems to be a high risk of superficial surgical site infection if the skin is closed. So when I close an abdomen after it's been temporarily closed for some days, I typically will leave the skin open and pack the wound. Occasionally, if the patient's only had an open abdomen for a day or two and didn't have GI spillage, I will close the skin loosely and use any of several techniques to try to minimize the risk of infection. Some patients, because of the amount of fluid resuscitation and edema that they develop, are not able to have their abdominal fascia closed. And the longer the fascia is open, the more the muscles retract to the side. So in that situation, we use a Vicryl mesh to protect the abdominal viscera. And then after granulation tissue has formed on it, we perform a split thickness skin graft. And as the scar tissue within the abdomen matures, which typically takes 6 months, may take a year or more, and can be assessed in clinic by pinching the skin graft. You know that the scar tissue has loosened and matured when the skin graft can easily be lifted away from the viscera. At that point, we perform a ventral herniorrhaphy, which typically involves some form of separation of components for the abdominal wall musculature to allow the fascia to meet in the middle. And it does appear that the rate of hernia repair failure is much increased if that hernia repair is performed in the acute setting. Now, after describing damage control, I will move on to operative techniques in hepatic trauma. As with any abdominal operation or operation in other parts of the body, the setup makes this much easier or harder, and there is no substitute in any operation for adequate exposure. So if the liver is injured, I make sure that my laparotomy incision runs cephalad up to the xiphoid, and occasionally I will even resect the xiphoid. Textbooks describe performing an 8th intercostal right thoracotomy, or a subcostal incision, or a right abdominal transverse incision. That one in particular I have used in training very successfully with elective liver resections. My personal experience, I have used both the 8th intercostal space thoracotomy and a right transverse incision for major liver trauma. In neither case did I feel that it assisted my visualization all that much. But those are options if you can't visualize the injured liver well enough. Wide mobilization of the falciform ligament is very important because as you retract the abdominal wall, you don't want to avulse the falciform ligament off of the liver and cause bleeding. I typically use a Bookwalter self-retaining retractor for all abdominal trauma cases. And while my hospital does have Thompson and Omni retractors, we don't use them frequently in our operating room suites where we perform trauma operations. But I know that those do provide somewhat better exposure of the right upper quadrant for my elective surgical experience. Packing, once the abdomen's open and you have identified a liver injury, should at least minimize this bleeding, giving you time to organize your approach, call a colleague for help if that's necessary, giving anesthesia time to resuscitate the patient, and giving you time to breathe and think through your next moves. And of course, lighting is very helpful, sometimes even a headlamp to allow you to visualize the deeper parts of the right upper quadrant.
Hello.
In the circumstances where I have preoperative, where there's preoperative imaging, where the patient was stable enough to undergo a CT scan, or in the case of penetrating trauma, where I have an estimate of the missile trajectory, I'm able to think ahead of time about what structures might be bleeding within the liver. Often with an exsanguinating patient, I've gone straight to the operating room and have to try to figure it out by staring at the liver. There are really only a few things within it that can be bleeding. Of course, the liver parenchyma will bleed somewhat when divided, but major bleeding typically comes from a vascular structure within it. Of course, that's the hepatic artery and portal vein coming in from below, and the hepatic veins at the top and the IVC behind the liver. I have occasionally in elective operations used intraoperative ultrasound to identify these structures. I have never attempted to do that in a trauma operation. I suppose it could be done, but I do try to keep a mental map of where these structures may lie, so that when I'm looking at the surface of the liver, I have some idea of what I may be dealing with. So this is I don't necessarily go through these in order, but I've tried to put together an algorithm for how I approach these injuries. The first step, which is often enough with a superficial laceration, is cauterization, either monopolar electrocautery. I typically will set the Bovie electrocautery to 100 or 120. I personally find that argon beam photocoagulation is much more effective for controlling ooze from liver parenchyma. Some of my partners swear by the Aquamandus, which is a bipolar cautery device seen in the bottom right here. And then there are a wide variety of topical products. I imagine they're known by different brand names in India from in the US. One I use the most is something called Surgicel, which is made of cellulose and provides a matrix for clot formation. But with a major liver injury, typically coagulation will not be enough. The first step is providing adequate packing. Laparotomy packs, of course, free up your hands and your assistant's hands to address other injuries within the abdomen, or to adjust your retractors. Typically, with a severe liver injury, manual compression from either side of the liver, squeezing the entire liver together is most effective, although not always effective with a major vascular injury within the liver. For gunshot wounds to the liver, Dr. Paghetti in Denver, Colorado described balloon tamponade for tamponade of missile tracts within the liver back in 1992. And I use this technique. In fact, I have a case study here I'll present in a few minutes that uses this. So that essentially is a homemade tamponade balloon that I assemble in the operating room by placing a catheter within a Penrose drain, which allows me to inflate the Penrose drain with normal saline and provide tamponade from within the missile tract. And then the catheter can be run through the abdominal wall and sealed off with a hemostat outside the abdominal wall and left until abdominal re-exploration in 24 or 48 hours. An alternative, which I have not used, but I know some of my partners have used, is a Bacri balloon, which is really designed to be an intrauterine tamponade device for obstetrics, but that can also be positioned within a missile tract and inflated to provide tamponade from within. Packing, especially if there's a major arterial injury within the liver, is often not enough. So if that doesn't control the bleeding, My next move is to perform the Pringle maneuver. As this illustration shows, I place my left index finger along the lateral surface of the gallbladder and sweep it behind the porta hepatis, and then up through the gastrohepatic ligament. If this substantially reduces bleeding when I compress this between my thumb and forefinger, as this illustration shows, a vascular clamp can be placed across the portal triad. I tend to use a Rommel tourniquet. I just find it keeps more instruments out of the way. This will control all inflow to the liver from the portal vein and the hepatic artery. It's diagnostic because if the hemorrhage from the liver does not decrease, you know that you're dealing with either a hepatic vein injury or an inferior vena cava injury, which will require some additional maneuvers to address. Of course, the downside of the Pringle maneuver is that you deprive the liver of any oxygen delivery at all. And so I never leave this in place for more than 30 minutes at a time, typically a bit less, 15 or 20 minutes. And if I still haven't done all the repairs I need to stop bleeding, I will release the Pringle and compress the liver, allowing it to perfuse and oxygenate for a few minutes before controlling the portal triad again. If it is the case that there is a major arterial or venous injury within the liver, the next step to address it is to mobilize the liver and make it more accessible. So the first step of that, which I've often already done, is to take the falciform ligament down from the anterior surface of the liver all the way back to the bare area using either scissors or cautery. And the key portion of that is to use your non-dominant, pull the liver downwards and extend the falciform ligament. The left triangular ligament, as that lower drawing shows, can be taken down in the same way by pulling down on the triangular ligament with your hand and then using electrocautery or scissors to divide it away from the diaphragm. For deep liver injuries in the right lobe, it's very helpful to release the right triangular ligament. I've never seen an illustration of this, and even when I do it, I usually operate more by feel than by visualization. I place my left hand inferior to the liver and lateral, and then sweep the hand laterally along the abdominal wall, and the triangular ligament will then tend over my index finger. And it's often difficult to visualize that, but I can palpate it and divide it with either scissors or electrocautery all the way up to the dome of the liver. Once the triangular ligaments and the falciform ligament have been divided, it's possible to rotate the liver almost medially into the surgical wound, which really makes it much easier to address injuries, especially of the right lobe and the inferior portions of the liver. Of course, the middle hepatic veins lie all the way back along the dome of the liver, and if you're not careful taking down these ligaments, you can injure any of the hepatic veins, which will make your liver injury oh so much worse. I typically leave the bare area of the liver alone unless I suspect that that's where my injury is. But of course, the liver can be separated from the diaphragm, and so it's attached only to the hepatic veins and IVC and porta hepatis. And the key step with that is to stay close to the liver parenchyma so you don't injure the diaphragm. With the liver now mobilized, if there's bleeding from within it, this can be exposed. Finger fracture is a perfectly acceptable way to divide the parenchyma. After fracturing, the remaining structures should be the larger arteries and veins and bioducts, which can be controlled with clips or sutures. I find it somewhat faster and less bloody to use an endoscopic GIA stapler to divide the parenchyma down to the area of concern. And that's done by inserting the thin arm of the stapler into the parenchyma a centimeter or two deep from the surface or from the previous stapler fire. And the key step with this is that if your stapler meets resistance, it's probably pressing into a large vessel. And so you shouldn't push it through extra resistance. I will create a new tract a bit shallower or deeper. Major vessels then can be exposed and controlled with either clips or personally, I prefer to use vicryl sutures, figure of 8 sutures to control vessels. And the exposed parenchyma and the injured parenchyma can be controlled with argon beam photocoagulation or another thermal cautery device. It is rare at the initial operation to need to perform a resection, but if there's a major destructive injury near any of the margins of the liver, sometimes the simplest way to fix it is to resect everything below either the missile tract or the contused liver. And again, here it's helpful to have a general sense of where the hepatic vein and portal structures lie. And that's performed in the same way as for exposing a missile tract or a deep laceration. If the Pringle maneuver has not stopped the blood flow from your liver injury and you continue to have active dark bleeding, you should be very suspicious of a hepatic vein or inferior vena cava injury. These are very bad injuries. Fortunately, in my career so far, I have yet to have a patient with a true infrahepatic IVC injury. But the mortality from these is very, very high, in part because they're very high flow vessels and in part because they are very inaccessible behind the liver. The first step, if you know you were dealing with this, which I did not put on the slides, is to pray to whoever may be able to help you. If you can control this with packing, and I have successfully done this with patients who were stable enough to undergo CT scan, and I knew they had liver injuries, I was very suspicious of an IVC injury. The best thing to do, if you can, is to control this with packing without mobilizing the liver. But if they bleed despite adequate packing, you're really forced into trying to address the bleeding. To get control of the IVC and give you time to repair it, the described technique was described in the 1960s by Dr. Schrock, and it's illustrated here on the right. This requires a median sternotomy and insertion of some large bore conduit, such as a chest tube, through the right atrial appendage, and securing the IVC around it, both above the liver and below the liver. Unfortunately, this is almost uniformly an unsuccessful maneuver, both because of the time it takes to perform, the difficulty of performing it, and the severity of these injuries. And what I believe is the largest series of these from Houston, Texas. Dr. Birch, Feliciano, and Maddox described 11 years of experience in which they performed this maneuver 31 times and had only 19% of patients survive. It is very helpful, I am told, to have 2 teams of surgeons to do this so that one team may continue operating in the abdomen while the other team performs the sternotomy and inserts the shunt through the atrial appendage. Assuming your patient hasn't bled to death, the next step, there is sure to be, by the time you've controlled bleeding from a major liver injury, the patient's nearly guaranteed to be coagulopathic. So the next step is to pack the liver in preparation for temporary closure. I try very hard to keep an accurate count of the number of laparotomy pads and other non-absorbable packing materials so that I know at re-exploration how many need to be removed. Also, if you've left temporary packing in the abdomen prior to fascial closure, delayed fascial closure, it's always good to get an X-ray of the abdomen to make sure there are no retained foreign bodies. Mostly I use laparotomy pads for this. I sometimes use, at least in the US, what's marketed as Quick Clot, which is a kaolin impregnated gauze. I believe it's sent into the field with US Army forces, and so it's also marketed as combat gauze. If you are confident bleeding's controlled and you're closing the abdomen for good, it's often helpful to leave vascularized tissue, such as an omental flap, against the cut or injured surface of the liver. I don't typically place a plastic drape directly against the liver. I'm not sure it's a bad idea. I know at least one of my partners frequently will use a plastic drape right on the surface of the liver with packing above that so that there's no sticking of the packing to the liver. which may, at least in theory, reduce bleeding when the packs are removed. Sometimes I'm very suspicious in these patients that they have a major arterial injury within the liver. And so my goal in the operating room is not to completely stop bleeding, but to slow it down enough that the patient can be brought to the angiography suite and have embolization performed, as these images show. After embolization, or if the patient won't benefit from embolization, they're resuscitated in the intensive care unit. If they're still bleeding, they should be rapidly, they should be re-explored, but I try to get the patient warmed to at least 36 degrees centigrade and have their coagulation parameters normal. Sometimes small vessels that may have spasmed and stopped bleeding in the operating room will start bleeding again once the patient is resuscitated, and often that is fixed by simply taking them back, removing the blood-soaked packing materials, and repacking the abdomen. At the time of reoperation and pack removal, if I'm suspicious that the patient may have arterial bleeding, I will call my interventional radiology colleague ahead of time and tell them, hey, this patient may need an angiogram if I stir up bad bleeding. I try very hard to remove any clearly devitalized liver parenchyma. And often there's a great deal of this around a missile tract or with a major laceration from blunt trauma. As this devitalized tissue will become necrotic and can easily become infected. My personal belief, based on no scientific literature, but just personal experience, is that any patient with a major liver injury should have a cholecystectomy performed, in part because critical illness can precipitate gallstone disease, and in part because the risk of gallstone disease over the remainder of the patient's life is often quite high, and the gallbladder will be quite surgically inaccessible after the adhesions form. And then finally, any major liver injury is likely to lead to leakage of bile, so I make sure to place typically 2, sometimes more, closed suction drains to control this. I'll go through the complications briefly and then do these case studies. So liver necrosis, you really should expect this, especially if the patient has also had hepatic arterial embolization. These patients typically have high fevers for some time after injury, often weeks. I believe, although again, I don't believe there's any evidence to substantiate this approach, but I believe that aggressive debridement of clearly devitalized liver parenchyma may minimize the fevers and the risk of infection. If the necrotic liver becomes infected, it typically will require percutaneous or open drainage, and occasionally for significant necrosis may even require reoperation and formal anatomic or non-anatomic liver resection. Bioleak typically occurs after a liver injury that's bad enough to warrant operative management. Closed suction drains usually are enough to control this. Occasionally, even with drains, they will not work well enough, and the patient may need a percutaneous collection drain. If the bioleak persists for some time, ERCP or percutaneous biliary drainage may be helpful at allowing the bile to drain either into the gut or externally and allowing the leak to seal. Hemmobilia is an uncommon complication, but may happen if there is fistulization from the hepatic artery into the biliary tree from the injury. And these typically respond well to angioembolization. And then I have read about in textbooks, but fortunately never encountered a condition called bilhemia, which is biliary fistulization into the hepatic veins, which causes a rapid rise in serum bilirubin without an increase in other liver studies. This can be diagnosed with ERCP and may require hepatic drainage or an external biliary drain with continuous suction to allow the bioleak to resolve. Acute liver failure is the worst thing that can happen after a liver injury and is fortunately very rare because the liver really has to be very severely injured for this to happen. It also is somewhat higher risk if the patient also undergoes hepatic angioembolization. There really is very little literature about this. I have personally managed 2 of these patients, both of whom ultimately died from this. There are case reports of successful liver transplantation for acute liver failure following hepatic trauma, but very few case reports. I found 3, including details on 4 patients in total. It's been, I guess at this point, 40 minutes. I am happy to take questions and have discussion, or I'm happy to go over case studies as well. I don't want to run too great on the time. I'll proceed with the case studies, but please feel free to interrupt me if you have questions, whether they're about the case study or not. So the first of these, and these are both from my past year here in Memphis, was a 34-year-old man who presented to the trauma center with a gunshot wound to his left upper quadrant and a gunshot wound to his right infrascapular back. On plain film x-ray, there were no retained missiles, so we knew that this was a single trajectory. In the resuscitation bay, he had hypotension and a severe metabolic acidosis, so he was taken emergently to the operating room. He had a right chest tube placed for hemothorax. He had an exploratory ciliotomy. His inferior vena cava was not injured, but he was bleeding substantially from his liver, which was controlled by essentially packing alone. The bleeding seemed to stop. A transdiaphragmatic pericardial window was performed, which ruled out injury to the heart. And the patient's abdomen was temporarily closed and he was brought to the ICU. My partner did his first operation and arranged for a hepatic angiogram after the operation, which showed an arterial portal fistula, and you can see the packing materials in place in the abdomen, from the proximal left hepatic artery. This was coil embolized, and you can see the coils lying here in digital subtraction angiography. One of the coils had inadvertently gone into the right hepatic artery, which our radiologist snared and removed. And you can see here the right hepatic artery opacifying normally. And he also shot a venogram, and you can see a normal inferior vena cava, and the right and middle hepatic veins appear normal in this image. So I did the patient's take-back operation on his 2 days later. As I removed the laparotomy packs, I encountered brisk dark bleeding from the dome of the liver. I performed a Pringle maneuver, and the bleeding may have slowed a little bit, but certainly was still quite brisk. And then I looked at the missile tract and saw the cut edges of a large vein, which was, by its position, obviously the middle hepatic vein. I then controlled I then tightened my Rommel tourniquet around the porta hepatis again to control inflow from the liver. And I encircled the hepatic vein distal to the injury with a vessel loop and repaired a 1 centimeter venotomy using running 4O polypropylene, and placed 2 Jackson Pratt drains and closed the abdominal fascia. The patient had a pretty uneventful postoperative course. From there, he was discharged 9 days from my operation, 11 days from his original operation. His drains still had bilious output, but that output dropped to nearly 0 at the time of his first clinic visit, 2.5 weeks from injury. He was last seen in clinic 2.5 months after injury, at which point he had some chronic chest and abdominal pain, but was otherwise doing quite well. And I think this case illustrates well how effective packing can be, even for a major venous injury. Completely controlled a large injury from a middle hepatic vein until the packing was removed. The second case, also a gunshot wound. We have, I believe, one of the highest rates of, highest proportion of penetrating trauma in the patients we get of any trauma center in the US. This is a patient I managed through and through, not completely perfectly, and I will talk about it. I think I made a mistake. I don't think it affected her outcome, but I will hope to do a little better next time. This is a 37-year-old woman who presented status post multiple gunshot wounds. She was hypotensive and confused with a severe metabolic acidosis. So she was intubated in the resuscitation bay. On physical exam, she was shot through her right upper arm with an unstable humerus fracture. She had a gunshot wound in her left upper quadrant and a retained missile in her right upper quadrant. And then she had gunshot wounds across her proximal thighs and labia majorum. with intact distal pulses. I gave her 3 units of packed red blood cells in the resuscitation bay, after which she had a normal or even slightly elevated blood pressure. I was a bit concerned that she may need operative intervention for her arm or legs, as well as her abdomen. So I took her for a CT scan of the abdomen and pelvis, going down through her proximal thighs. And fortunately, the thighs, only muscle was injured, no vascular injury. But in her abdomen, as you can see here, there is a extensive necrosis and active extravasation along the missile tract through the right lobe of her liver. At this point, I believe I became overly optimistic. The patient was still quite hemodynamically stable. I knew that she would need a laparotomy for the control of her injuries, but I thought the amount of bleeding I encountered would be much less if I could get her hepatic artery branches embolized first. So I consulted interventional radiology. Unfortunately, this happened in the middle of the night, and it took about an hour to an hour and a half for interventional radiology to be ready to perform the angiogram. In the meantime, the patient became hypotensive, and I took her immediately for laparotomy. I found a large amount of blood and clot in her abdomen. Fortunately, no injuries other than her liver, with a hole in the inferior right lobe and a hole in the anterior surface of the liver adjacent to the falciform ligament. The bleeding was reduced somewhat, although it wasn't stopped, using a Pringle maneuver. So then I used a long bowel clamp to pull a homemade spaghetti balloon tamponade device through the tract and inflated that with normal saline, which did a wonderful job in minimizing the amount of hemorrhage. I then packed her with laparotomy pads over, under, and lateral to the liver and placed in a temporary abdominal closure device, brought her to the intensive care unit for resuscitation, where she had continued bleeding from the VAC dressing. Based on her preoperative imaging, I called interventional radiology again, who came in. I think they were already pretty much set up, and performed a hepatic angiogram. You can see here extravasation here and here from branches of the bilateral hepatic arteries. My colleague from radiology coil embolized numerous branches to segments 2, 3, 6, and 7. And following this, the patient was brought back to the ICU. She continued to have bleeding through her VAC dressing. And so I took her back to the operating room, took out the bloody laparotomy packs and repacked them, after which she was very stable. 2 days later, I took her back to the operating room. She was well resuscitated at this point. Her gallbladder was frankly necrotic, and I performed a cholecystectomy. I deflated the balloon through the missile tract, and there was a very small amount of bleeding from the tract, from some small, about 2 millimeter veins. I controlled that bleeding with surgical clips, but there's a large amount of necrotic liver anterior and inferior to the missile tract through the middle of the right lobe. And I debrided as much of the clearly necrotic liver as I could, using an endo-GIA stapler and argon beam photocoagulation on the raw surface. I then covered the cut edge with fibrin glue and Surgicel, which is a cellulose-based gauze, and then omentum, placed Blake drains, and temporarily closed her abdomen. 2 days later, one of my partners took her back to the operating room, thought that we would probably not be able to ever close her fascia due to the amount of edema of her abdominal viscera, and so placed a Vicryl mesh. Unfortunately, I was quite happy about how things had turned out at this point, and was thinking this was going to be one of my best cases here. Unfortunately, she had a very difficult post-operative course. She developed a persistent bioleak, and these became infected, requiring multiple percutaneous drains. She developed severe ARDS, likely secondary to her massive transfusion. I don't know the total number of blood products she received, but I think it was probably in the realm of 80 units of packed red blood cells and plasma and platelets. She developed barotrauma from the ventilator and required bilateral chest tubes. And unfortunately, this happened in July of this year. She seems to have become infected with COVID-19, likely from one of the other ICU patients or staff. She developed an acute kidney injury requiring continuous dialysis, although that did eventually resolve. And then over the course of several weeks, she had multiple bleeding and clotting complications, including a hemothorax and a iliac DVT. Her respiratory function eventually recovered. She came off the ventilator, was transferred out of the ICU, and we were preparing her for discharge from the hospital when she was found unresponsive early one morning. And on CT head, found to have a large hemorrhagic stroke, which neither I nor any of my partners can quite explain, other than perhaps some coagulopathy from her related to her COVID-19. And she expired, unfortunately, from this hemorrhagic stroke. But despite the poor outcome, I think this case does illustrate both a variety of technical maneuvers, which were key to controlling the bleeding, as well as an interplay between operative interventions, angiography, and intensive care. In this book, I put this in, it seems like the audience are mostly senior consultants. I put this book in, it's really geared perhaps more to trainees, but may also be of interest to anyone who performs trauma surgery occasionally. It's a very colloquially written, but well illustrated book. I have no financial relationship to this or any of the products I've spoken about, but this is a book that I read numerous times as a trainee, which gives a very hands-on, readable account of how to approach a patient with major abdominal trauma or vascular or thoracic trauma. Thank you very much for the opportunity to speak with you.
Thank you so much, sir. It has been, you have done a very heroic in leg surgery. Would like to ask if anyone wants to ask any questions. Dr. Chaudhary, sir?
Let's NND ask question. NND.
Dr. Ananda,
Professor, am I audible?
Yes, you are.
Yeah. First of all, thank you so much for your elaborate description of liver injury. I want to share some of my experiences of a liver injury. And first of all, you said the suturing of the liver sometimes with a vicryl and all. But what is your, opinion of the suturing of the liver? Actually, I use a monofilament suture in case any suture to be done for some superficial liver injury. And the second question is the packing of the liver. I have experience of packing of the liver around 10 cases in last almost 10 years. But the result is, disaster, and the most of the time the bleeding stopped, the patient died because of the sepsis. So, and I do not know, actually, after all the precautions also, I work in a tertiary center, but after, with all precaution also, the sepsis was the major cause of the death of the patient. And the third thing is that the left-sided liver injury probably, not very difficult to manage because you can quickly go for a, some kind of an excision of the lacerated injury of the left side of the liver. The major problem of the injury on the segment 7 and 8, because it lies posteriorly and very close to the middle hepatic vein, the right hepatic vein. In that scenario, you are in a big problem actually. I'm not talking about a gunshot injury. I'm talking about a blunt injury of that.
Sure.
And in one case scenario, you mentioned about the middle hepatic vein repairing and all. As a little bit of, I just want to differ on that. Instead of repairing, if you just had to close the middle hepatic vein, would there be any harm to the patient? Because the middle hepatic vein have got the segment 5 and 8 and segment 4 and A and B has got some venous drainage to the left hepatic vein as well as to the right hepatic vein. Because in that scenario, in the middle hepatic vein, there is always a chance of air embolism and all. So these are my couple of questions and my experience also. But my experience of packing is not very good. And in fact, the sepsis is the biggest problem.
Sure. So with packing, I mean, certainly the patients who survive a major hemorrhagic trauma very frequently get multi-organ system failure, and many of these patients who end up dying die of either sepsis or bizarre reactions to physiologic stress, such as the patient who had the hemorrhagic stroke. The packing, if it's left too long, seems to become colonized and quite likely infected. I have always taken the packing out within 72 hours, maybe occasionally longer than that. Occasionally, when I've explored a patient closer to 72 hours or longer, often the packing has a foul odor. And I believe it even if the abdomen doesn't have spillage within it, there ends up being some level of bacterial contamination. I don't have, because that's how I've always, in training and in my own practice now as a senior physician, I try very hard to take the patient back, ideally within 48 hours. And even if there is still continued bleeding that requires packing, to take the packing out and lavage the abdomen with 4 or 6 or even 10 liters of saline. And then if there's continued bleeding, can be repacked with new sterile laparotomy pads. I think if the packs are left in place for more than 72 or perhaps even more than 48 hours, the risk of colonization and infection goes up significantly. Bioleak, I've had several other patients as well as this patient who have leaked bile from their injuries that was not well controlled by drainage and has become infected and has been a big problem. In fact, one of the patients I was reviewing as I was thinking about this talk was a patient from my fellowship who was another gunshot wound patient who had required a nephrectomy as well as the Paghetti tamponade balloon, and basically formed an infected biloma in his nephrectomy bed, which subsequently required reoperation 3 weeks out from his initial surgery and liver resection. Although he ultimately did okay, but in the meantime, the infected biloma had caused him to become fungemic and very high fevers. I don't know if I haven't had, other than infected bilomas, I haven't had, in my experience, or patients being presented in conferences, major problems with sepsis, as long as the packs are removed within 2 to 3 days and the abdomen's thoroughly lavaged before either new packing is placed or the abdomen's closed. I think your comment about the middle hepatic vein is entirely correct. I remember discussing with my trainee in the operating room how there was probably no downside to ligating it instead of repairing it. There is, I'm sure, was some risk of air embolus, a small air embolus to the lungs, as long as it's small, I think is of little consequence. And I chose to repair it because it was readily repairable with a short suture line. I thought it would be good practice for my trainee as well. But I strongly doubt there is any negative effect on liver function to ligating a hepatic vein. And I'm sorry, sir, you had one other question at the beginning, which I haven't addressed.
Suture, regarding the suture.
Oh, yes.
I prefer to use a monofilament suture.
Yeah, so it's been a long time since I've had a liver injury that I thought was appropriate for this, but I should have put in one of the major techniques for liver injury, especially a linear crack in the liver without extensive amount of mushy contused tissue, is a very large sutures. Typically, we'll use a number 2 chromic gut suture on a blunt needle to approximate the liver on either side and provide tamponade. And that can be done either just approximating the liver, or you can insert some sort of absorbable hemostatic product in the middle or omentum. I neglected to include that in my slides at all, just because I as an oversight because I haven't actually had a patient who that was appropriate for in a while. When I use, I believe I put a reference to using 2.0 braided absorbable suture, and that was more to control an injured vessel within the parenchyma rather than to approximate the parenchyma itself.
Okay, and what about the segment 7 and 8 injury? I mean, because these are very difficult to manage on segment 4.
Very difficult to manage, primarily because of their depth within the right upper quadrant. So I think the key maneuver for that, if they can't be controlled with packing alone, the key maneuver is to divide the right triangular ligament. And so I believe, I'm quite positive you have to take down the hepatic flexure first, and probably need to medialize the duodenum with the Coker maneuver. And then you can slide your hand up the retroperitoneum inferior to the liver, or rather posterior to the liver, and sweep laterally along the abdominal wall and tenth the hepatic vein, the hepatic ligament rather, over your index finger, and then can divide that with scissors or cautery, which allows you to rotate the liver up. And I'm not going to say that it makes segments 7 and 8 easy to visualize and operate on, but it makes them substantially easier to visualize and operate on than leaving them in sight without dividing the triangular ligament. But you're absolutely correct that that's a difficult place to operate. They can be, you know, if it's a
but the thing is that you likely to cause some pressure on the IVC while you giving the packing for the segment 7 and 8 injury. You know, the IVC pressure. Yes. I mean, because it is very close to the IVC, so that's why I mean the packing also have got some, you know, the outflow maybe. I mean the inflow of the maybe some compromise in a situation like that.
Absolutely. It may be difficult or even impossible to provide adequate tamponade with your packs without occluding the IVC. If it's a fairly superficial, relatively superficial injury in that area, I think a non-anatomic resection may be the best option, using either finger fracture or the endo-GIA stapler, and just removing the contused or lacerated liver, just as you would for the left lateral segment.
Mr. Hawley?
Thank you, Professor Hawley. Over to Professor Jaman, please. Yeah.
Yeah. Mr.
Yes,
Hawley, nice presentation. And the fact, can you hear me?
Yes, sir.
Yeah. Packing, no doubt, is a time-tested method, and very many surgeons have used with good results. And as you have said, early removal is important, maybe within 72 hours. Now, my question is regarding laparoscopy. Any role of laparoscopy in liver injury for preliminary assessment and all?
So I think there is a role. This gets talked about much at trauma conferences. I think on a kind of systems level, the problem with advancing laparoscopic trauma surgery is that at most of the busy trauma centers, the trauma surgeons such as myself rarely use laparoscopy, and so our laparoscopic skills, which I feel like I developed a fair amount of them in my residency training, really have atrophied somewhat. So the way I use laparoscopy is pretty much limited to assessing, in a stab wound or a gunshot wound, whether the peritoneal cavity has been violated. In particular, I don't feel confident that I can run the small bowel as well laparoscopically as I can in open surgery. With the liver specifically, I think, I've done a few in training. I did a few hepatic tumor resections and even major lobectomies laparoscopically. But I don't feel that my laparoscopic liver surgery skills are all that great. But I think even if I were much more confident in my laparoscopic skills, I would hesitate to use them for liver injuries, because most liver injuries that are bleeding so much to require an operation that can't be managed non-operatively, I think it will be very difficult. First of all, if the patient's bleeding that much, they're unlikely to tolerate pneumoperitoneum. And also it can be, of course, bleeding limits your visualization much greater in laparoscopy than open surgery. So I think the ability to explore the liver adequately and to deal with major hemorrhage is much less in laparoscopy than in open surgery. So in my practice, I don't think there's any role for it. I have worked a bit in training with some surgeons who took trauma call at a relatively busy trauma center, but mostly did elective general surgery. And I think they may be much better equipped to deal with injuries laparoscopically because of their frequent elective use of laparoscopy than I am. But I still think most liver injuries requiring an operation are going to be bleeding too much for that to be a great technique.
Injury. And another question, any change in your strategy in case of children?
I'm sorry, sir. Due to the connection, I couldn't hear you.
Any change in your strategy in case of children with liver injury?
I consider myself fortunate enough to work at an adult trauma center and have no personal role in the management of injured children. All I can tell you is a general rule that children, I imagine, like as for a splenic injury, children are better able to tolerate non-operative management. But otherwise, it's really outside of my day-to-day clinical experience, and I don't have any particularly helpful guidance. We're about 1 city block away from the pediatric trauma center, and it's quite rare that we get a severely injured child in my hospital.
Thank you so much. Thanks.
My pleasure.
Dr. Hawley,
Yes, sir.
I have a question to you. Do you do any pre-packing assessment, radiological assessment like CT or CT angio? Because what I'm asking is, after removal of packing, sometimes you have re-bleeding. Do you have incidents of re-bleeding in your case, and how do you manage those cases?
So I'm trying to remember if I've had a personal experience with this. I know I've taken care in fellowship. I've taken part in the critical care of patients who've had this happen, and it is a real issue. Unfortunately, in my hospital now, we don't have these resources. But where I was a fellow, we had a hybrid operating room that with an image intensifier, allowing us to do angiography in a true operating room. Since we had that capability, all of the packed livers were taken back and their reoperations were performed in that operating room. And probably we did more of this than we needed to, but our standard was to do a hepatic angiogram after removing packs in all of those patients. In part, I think we did that because we had the capabilities and we're trying to make the most use of our hybrid room. But there are patients, especially with the intrahepatic balloon tamponade, pretty frequently there are major arterial injuries that may have been controlled successfully with the packing. In my hospital, when I'm removing packing from what I think is a bad liver injury, I call our interventional radiologists ahead of time and say, hey, I'm taking these packs out. Please be ready for me. And I try to coordinate that with them. Fortunately, have not yet had an experience where I had to rush a patient up to interventional radiology. Of course, the downside of packing, if the packing has controlled your arterial bleeding, you may not see it on CT scan. So I think it's a possibility. Fortunately, it's fairly rare. Most small arteries that you can control with packing will spasm and thrombose within 48 hours. I don't think we have any evidence to support it, but typically, if it's a particularly bad liver injury, we will wait at least 48 hours to re-explore them, just to give extra time for arterial injuries to resolve on their own with tamponade.
Yeah, Professor Auli, it's great listening to you. I have been enjoying your talk, though you're far away. Anyway, sir, my query is there any experience of you regarding the portal injury and SMB?
It's been a universally depressing experience. I consider that someone outside the talk, so I didn't try to include any of that in my slides. Of course, these are very bad injuries. I'm trying to remember if I believe I've had one penetrating and one blunt. I remember the blunt very clearly. That patient died on the operating room table. He was very severely injured and had extensive adhesions from, I believe, a colon cancer operation, and had completely avulsed his SMA, as well as nearly ruptured his descending thoracic aorta. More commonly, I mean, these are rare injuries, fortunately, more commonly in penetrating trauma than blunt trauma, but they definitely occur in blunt trauma as well. And the great risk, as I'm sure you know, with a portal vein injury or a superior mesenteric vein injury, if the venous drainage of the bowel is compromised too much, there can be venous congestion and ischemia of the small bowel, which is maybe not an absolute rule, but in the real world, a universally fatal complication. So when I have major venous injuries such as this, I've also used this technique for the inferior vena cava. Since it certainly is described to ligate the SMV or the portal vein, and if that controls the bleeding, not every patient will develop fatal mesenteric ischemia, but some will. My preferred technique is to control the venotomy if it's not a complete transection, if it's a lateral injury, to control the venotomy using Judd Alice clamps, which have a softer grasp than a regular Alice clamp, and I'll use that to approximate the venotomy. Use several of those clamps, and then use polypropylene suture to sew underneath the clamps, removing them as I go, which will narrow the vessel somewhat, but hopefully leave it patent. I actually wrote up, at the end of my fellowship, I wrote up 10 years of our hospital's experience with SMV and portal vein injuries. The major conclusion from that study, I believe it was only 26 patients over 10 years. The major conclusion was that if the first attempt at hemostasis is unsuccessful, the patients always died. So you really, you have to be quick with them, and you have to commit to some plan. And if it doesn't seem reconstructible, then ligation and hoping the patient doesn't develop catastrophic venous ischemia, I think, is your best option.
Okay, so thank you, sir, for very informative. You have been, and I have been following your article also. And in one article you have just mentioned regarding one of the studies in epidemiological, though it's directly not related to this particular talk, but you have mentioned regarding that epidemiological study in somewhere in Hyderabad.
Oh yeah.
So what is the difference of this there's factors from India and your USA, that the accident, that etiological factors which are mentioned about?
I mean, I've never worked clinically in India. During my surgical residency, I took 2 research years, and my research mentor had done some work through grant funding and also through the WHO, including running an injury surveillance program at Gandhi Hospital in Hyderabad. So I got to go with them actually and perform a 2-day trauma training course for their nurses and trainees, and got to tour the hospital. But that's the closest I've ever come to clinical work in India. My impression, I have worked, and I imagine the resource constraints are similar in this setting compared to the US. I did work for 5 weeks in Cape Town, South Africa, at a large public hospital, which seemed to have a similar level of resources to Gandhi Hospital in my more limited experience there. I mean, certainly in the US, the resource constraints are lower. They're still real, and they're also different. I know in South Africa, they were much more thoughtful about CT scan. In the US, in part because we have the resources, and in part because we're very afraid of being sued for malpractice if we miss an injury, we are very liberal with the use of CT scan. And I've never worked anywhere where this has been a problem, but always at trauma conferences, there's somebody from some hospital that advocates CTing even hypotensive patients. And I think, apart from resource use, and especially with regards to imaging, I think one of the other major differences, I mean, the US, in addition to being a very wealthy country, is a very violent country with a large amount of firearms. And so, I mean, I frankly enjoy operating on firearm injuries, but it really is somewhat depressing how many of them we have. Also, my brief experience of India is that maybe the rate of traffic collisions is, I believe, much higher in India than in the US. The use of safety equipment such as seatbelts and airbags is much lower. But the highway speeds in India tend to be much lower than the US, where, on major highways, or if people are intoxicated, they often drive at 120 or more kilometers per hour. So different injury patterns.
Thank you, sir. Thank you very much.
My pleasure.
Thank you so much, sir. Anyone of the panelists would like to ask any questions?
Yeah.
Dr. Chandra Bora.
Professor Howley?
Yes, sir.
Am I audible? Hello?
Yes,
Yeah.
sir.
Yes, sir. Sir, Professor Howley, very nice presentation. My question is that we have also found a lot of liver injury. Most of the time we pack for 48 hours to 36 hours. And we remove it and bleeding usually stop. And my question is, and most of the time we suicide get that out. My question is, if you get the case with liver injury along with the CBD injury, how will you manage it? What is your
I'm sorry,
opinion?
one more time, sir?
Pardon, sir?
Liver
Liver and CBD injury. Liver with CBD injury. Common bile duct injury.
Liver injury with
injury.
bile duct injury.
Bile duct injury.
So within the liver parenchyma, I essentially just ligate any major bioducts I see. I'm sure there's some consequence to that, but I think it's probably not worth attempting biliary reconstruction within the liver. I'm trying to think. I have done a great deal of oncologic biliary and pancreatic resections. I don't believe I've ever personally repaired a injured common bioduct. I mean, the biggest challenge with that is that they tend to also have extrahepatic portal vein and SMV injuries. Yeah, I'm sure at some point I'm going to be staring at a injured common bioduct. I think unless it's a very small injury, you should expect that even if you resect and repair it, there will be stricturing. I think you're required to either leave a T-tube for external drainage, or probably the best case with most injuries is to perform a hepatico-jejunostomy. But fortunately, I have not, in my short career at this point, had to deal with one of them.
Can I add a few lines about the bile duct injury on the hepatic trauma? I have managed one case few years back, a longitudinal injury of the CBD, along with the injury extending to the left hepatic duct. And the bile duct was very small, actually 4 mm, 5 mm bile duct. And we repaired with a 5-4 this PDS. And on follow-up, the patient was not having a problem. So, and as Dr. Howley has rightly said, that this patient always likely to have a stricture in the long run. But, in an emergency situation, you have to repair it, and better to avoid the hepatico-jejunostomy, because if later on, if there is a stricture, in that case, it will be easier to manage, because if you straight away go for a hepatico-jejunostomy, so later on it might have a problem. So I have got only one experience, and that's the patient. It was a young patient of 20 years old, having motorbike accident and all, but patient is still doing good and all. That is one of my. You may is maybe thinking. I mean, take it as in my anecdote also. It is not only one cases.
That sounds like an excellent case, though. My congratulations.
I think we'll come to the end of this session. I would like to, anyone would like to ask the questions? Dr. Rukmana, anything regarding from your angle? Okay, then I would like to request Dr. Sarvesha Bora sir to kindly close the program.
Regarding this abdominal trauma. I also say that this webinar is becoming very helpful. There are so many questions coming from my participants. It indicates that it's a very nice and very elaborate talk. I'm going to just thank to Dr. Isaac. Also, I thanks to the participants who has taken active participation in this webinar. I hope that in future also we will continue to do this type of webinar and all the citizens of Assam and Nexus region will be beneficial from such type of webinar. And again, very heartiest thanks to Dr. Isaac and all of our participants. Thank you. Thank you. That's right.
বৰা স্যাৰ আপোনাৰ একচুয়ালি আপনি ইয়াৰ প্লাগটো খুলি পেলাই ক'লে বেছি মানে শুনা পালে চাগে ইয়াৰ পিছৰ পৰা কৈ আছে তো আপনি ইয়াৰ পিছটো খুলি পেলাই ক'লে বেছি ভালকে শুনিব because of the word has been not been clear actually.
Chaudhary sir, would you like to say the final words?
Yeah. Dr. Howley, thank you very much for accepting our invitation and giving a very extremely good lecture on hepatic trauma and your experience of how to manage it. We have learned a lot from you and we have been able to share our experience also. I also thank Dr. Nabajit Chaudhary, who has been the connecting point between me and Dr. Howley. So thank you very much for giving this opportunity. At the end, I think we'll be having you again in future. And thank you very much at the end. And thanks all our participants and the moderators. Thank you very much.
Thank you very much. It's been a great experience getting to speak with you.
Yeah.
Thank you.
Rocket.
Can I leave?
Can you hear me?
Yes sir, শুনি আছো স্যার
আমার বড় স্যারে কি সিস্টেম ইউজ করে যে মাত্র না হয় যে কিও
স্যার বড় স্যারে মানে ইয়ার প্লাগ মানে কি কয়